We are now going to discuss the colon. This includes GI bleeding, diarrhea, irritable bowel syndrome, inflammatory bowel disease, diverticular disorders, and colon cancer screening. A 69-year-old woman comes to the emergency room with multiple red-black stools. Her past medical history is significant for aortic stenosis. Her pulse is 115 and her blood pressure is 94/62. Her exam is otherwise normal. What is the next best step in managing this patient? Is it A, get a colonoscopy, B, place an NG tube, C, an upper endoscopy, D, a bolus of normal saline, E, a CBC, F, bolus D5, G, call gastro, or H, check for orthostasis? The correct answer here is D. The precise etiology of the severe GI bleeding is not as important as fluid resuscitation. There's no point in checking for orthostasis when the person's systolic blood pressure is already under 100. Furthermore, she's tachycardic at rest. What's the point of checking orthostasis? Endoscopy should be performed, but it's not as important as first fluid resuscitating her. When blood pressure is low, normal saline or Ringer's lactate are better fluids than D5. D5 does not stay in the vascular space to raise blood pressure as well as normal saline. So what's the take-home lesson here? Remember, D5 is not a good fluid. It doesn't stay intravascular, but the patient is unstable. You must stabilize her first, then diagnose her. That's why it's called the ABCs: airway, breathing, and in this case, circulation. The most common cause of gastrointestinal bleeding from above is ulcer disease. Other causes of upper GI bleeding that are not as common are esophagitis, gastritis, cancer, duodenitis, and variceal bleeds. The most common cause of lower GI bleeding is diverticulosis. Other less common causes are polyps, inflammatory bowel disease, cancer, a very brisk, rapid transit, high volume upper GI bleed, and lastly, hemorrhoids. We saw with the first question that GI bleeding can have a profound effect on hemodynamics. When a patient is orthostatic, they've lost 15 to 20% of their blood volume. When they become tachycardic, they've also lost 30%. When their systolic blood pressure is less than 100, they've already lost 30% of their blood volume. The most important key step here is resuscitation. Remember, orthostasis is defined as a greater than 10-point rise in the pulse when going from supine to sitting or standing up, and a blood pressure drop of 20 points or more when sitting up. Variceal bleeders will present with hematemesis with possible black stool. The only form of GI bleeding in which physical exam helps to determine the etiology is variceal bleeders. The signs of liver disease help establish the diagnosis. Variceal bleeding is suspected when the case describes a patient with cirrhosis, spider angiomata and caput medusa, splenomegaly, palmar erythema, and asterixis. For acute severe bleeding, you want to replace the fluids, check the hematocrit and platelet count, and find out what the coagulation parameters are. There is an association with higher mortality as the INR rises. For variceal bleeders, the next best step is octreotide followed by urgent upper endoscopy to control the bleed by banding. There are a variety of additional diagnostic tests for GI bleeding, but they all have very narrow indications. A nuclear bleeding scan is used when the endoscopy has failed to reveal the source of the acute hemorrhage. Angiography is used when specific site of bleeding needs to be identified prior to surgery or embolization of a vessel. Remember, it's used only in massive, non-responsive bleeders. Capsule endoscopy is used when a small bowel bleed is suggested. This is when upper and lower endoscopy does not show the etiology of the bleed. A CT and MRI of the abdomen, well, they're pretty much useless in GI bleeds. An EKG, however, can show ischemia in severe bleeding and give you an idea of how well you're doing in controlling the hemodynamics. The next best step in treating a patient with GI bleeds is to stabilize them. Fluid replacement with high volumes, that could be 1 to 2 liters or more an hour of normal saline or Ringer's lactate in those with acute severe bleeding, has been shown to better outcomes. Giving packed red blood cells if the hematocrit is less than 30 in those who are older or suffer from CAD is beneficial. If the patient is young, transfusion may not be needed until the hematocrit is very low. such as in those with 20 to 25 range. The next component of stabilization is to correct a coagulopathy. Fresh frozen plasma is given if the PT or INR is starting to rise. If the INR is greater than 1.3, you must give FFP. A high INR is associated with higher mortality. Furthermore, if you're giving more than 4 units of packed red blood cells, you must keep in mind the patient may develop a dilutional coagulopathy. Since PRBCs don't have clotting factors, when you give too many, you dilute the plasma. This causes the INR to rise, so consider giving FFP in this case as well. For platelets, if the count is below 50,000 and there is bleeding, you should consider giving platelets as well. The next best step in patients with GI bleeds is to treat the underlying cause. Endoscopy to determine the diagnosis and administer treatment is of the utmost importance. You can ban varices, cauterize ulcers, even inject epinephrine into bleeding gastric vessels. All patients with upper GI bleeding must be on intravenous PPI therapy. Remember, it doesn't matter which PPI, they're all the same. The last resort is surgery. This is essentially to remove the site of bleeding. This happens if fluids, blood, platelets, and plasma will not control the bleed. Some patients will present with gastrointestinal bleeding due to esophageal or gastric varices. These patients in history will have chronic liver disease, specifically cirrhosis. Octreotide or somatostatin is used to decrease portal hypertension. Banding can then be performed by endoscopy to obliterate the esophageal varices. Keep in mind, sclerotherapy is never the right answer if banding is technically possible. Transjugular, intrahepatic, portosystemic shunting is used to decrease portal pressure in those who are not controlled by octreotide or banding. Propranolol is used to prevent subsequent episodes of bleeding. It's prophylaxis. It will do nothing for the current episode of bleeding. There are 5 kinds of diarrhea you need to know for the step 2. The first is lactose intolerance. The second is antibiotic-associated diarrhea. The third are those patients who chronically malabsorb. The fourth are those patients who have chronic pancreatitis. And the last one you need to know are those patients who suffer from carcinoid syndrome. Clindamycin has been associated with the highest incidence of antibiotic-associated diarrhea and the occurrence of C. diff. These patients will present with blood and white cells in the stool, but they may not always be present. These patients will present several days to even weeks after starting the antibiotics. Some of them will have finished the antibiotics. They will then present to you with profuse diarrhea. Keep in mind, though, any antibiotic can potentially cause antibiotic-associated diarrhea. Clindamycin just happens to have the highest incidence, but it could be any one of them. The best initial test is a stool C. diff toxin assay. The most accurate test is a C. diff PCR. The best initial therapy for antibiotic-associated diarrhea is another antibiotic, specifically metronidazole. If there's been no response to metronidazole, the next step in management is to switch to oral vancomycin or a new drug, fidaxomicin. Remember, IV vancomycin is always wrong for antibiotic-associated diarrhea since it will not pass the bowel wall. A 75-year-old male is admitted to the hospital with pneumonia. Several days after starting antibiotics, he has diarrhea. A stool C. diff assay is positive. He's then started on metronidazole, which leads to the resolution of his diarrhea over a few days. 2 weeks later, however, his diarrhea recurs and the C. diff toxin is positive again. What's the next best step? Is it A, retreat with metronidazole, B, give him oral vanc, C, perform a sigmoidoscopy and treat only if pseudomembranes are found, D, intravenous metronidazole, E, wait for a stool culture, or F, intravenous vancomycin? The best answer here is retreat with metronidazole orally. Recurrent episodes of C. diff-associated diarrhea are best treated with another course of metronidazole. Now let's go through the wrong answer choices. B and F are wrong because using oral vanc is not indicated yet. You must fail 2 courses of repeat metronidazole before switching. Intravenous vanc, as we just discussed, is always the wrong answer. It doesn't cross the bowel wall. A sigmoidoscopy and treating only if pseudomembranes are present is not necessary. This patient has had 2 positive C. diff assays. Intravenous metronidazole is only if the patient cannot take oral medications. And lastly, waiting for the stool culture is not correct for 2 reasons. Number 1, you have a positive C. diff assay. Number 2, C. diff does not grow in a culture. Therefore, this choice is completely wrong. Let's go through the decision tree for this form of diarrhea. Is there diarrhea after antibiotic use? If you answered yes, you must check a C. diff toxin assay. If this toxin assay is not positive, you must consider alternative causes, or you can consider doing a C. diff PCR if clinical suspicion is high. If your C. diff assay is positive, you treat with metronidazole. The next question you're going to ask yourself is there improvement? If there is improvement, you continue metronidazole until the end of the antibiotic course. If there is no improvement, you switch to oral vancomycin or fidaxomicin. Let's talk about malabsorption. All patients with malabsorption are going to present with steatorrhea. What is steatorrhea? These are patients who have oily, greasy, floating, foul-smelling stools. The causes of malabsorption can be one of 3 items. The first is celiac disease. It's one of the most common types and can present as an adult. Whipple's disease is a rare syndrome, but we will talk about it. Chronic pancreatitis is a similar presentation with fat malabsorption. There are some other rare causes, such as tropical sprue. We're going to discuss all these in the upcoming slides. All forms of fat malabsorption present with deficiency of fat-soluble vitamins, specifically vitamins A, D, E, and K. Therefore, if you're malabsorbing, you're going to manifest the signs and symptoms of the particular deficiency. A vitamin D deficiency will lead to hypocalcemia. A vitamin K deficiency will lead to bleeding and easy bruising. It's like you're on Coumadin. Remember, Coumadin antagonizes vitamin K. Vitamin B12 deficiency will lead to anemia, hypersegmented neutrophils, and neuropathy. Remember, vitamin B12 needs an intact bowel wall and pancreatic enzymes to be absorbed. Patients who are malabsorbing have no intact bowel wall. Now you might be wondering why I didn't mention vitamin A or vitamin E. Their clinical manifestations are not significant enough, nor are they tested often. If you're wondering, a vitamin A deficiency will lead to a difficulty in night vision. Vitamin E plays a role as an antioxidant and in skin. You may have some form of manifestation there, but again, the USMLE will be unlikely to test you on it. The best initial test for celiac disease is an anti-tissue transglutaminase antibody. The most accurate diagnostic test is actually a small bowel biopsy. It will reveal flattening of the villi. We also like the biopsy because it can help us exclude lymphoma. Other tests are the IgA anti-gliadin antibody and the anti-endomysial antibody. Remember, celiac disease gives dermatitis herpetiformis in about 10% of cases. Whipple's disease is a rare systemic infectious disease caused by the bacterium Trophorema whippleyi. It causes invasion of the small bowel villi and can lead to fat, floaty, foul-smelling stools. It's also associated with arthralgias, ocular findings, neurologic abnormalities such as dementia and seizures, fever, and nonspecific lymphadenopathy. The most accurate test for Whipple's disease and tropical sprue is obtaining a bowel biopsy showing the specific organism. In Whipple's disease, you're going to reveal the presence of an organism that will read as the following: a PAS-positive, non-acid-fast macrophage inclusion. The way you treat them is with ceftriaxone or trimethoprim sulfamethoxazole. Chronic pancreatitis can be diagnosed with abdominal X-ray. It is 50 to 60% sensitive for calcification of the pancreas, but it's very specific when the test is abnormal. You can see here an image on the right that shows chronic pancreatitis that has led to calcification of this patient's pancreas. An abdominal CT scan is actually 80 to 90% sensitive for pancreatic calcification. Therefore, it is a much better test than the abdominal X-ray. You can see here on the right an image of a patient's pancreas with calcifications riddled throughout it. Secretin stimulation testing is the most accurate diagnostic test for chronic pancreatitis. The way the test is done is an NG tube is dropped down past the pylorus. Then IV secretin is given, and we look for a large volume of bicarbonate-rich fluids to be released. If it is not, we know there's something wrong with the pancreas. This test has a 95% sensitivity. D-xylose testing is an old test to distinguish pancreatitis from bowel wall abnormalities. D-xylose is normal in pancreatic disorders. For patients with chronic pancreatitis, the specific treatment is enzyme replacement. For those patients with celiac disease, the treatment is to avoid gluten-containing foods such as wheats, oats, rye, and barley. For Whipple's disease, we treat them for a very long time, up to a year in some cases, with ceftriaxone or trimethoprim sulfamethoxazole, which is also known as Bactrim. For tropical sprue, we do the same thing. We consider Bactrim or tetracycline for a very long extended course. Carcinoid syndrome will present with flushing, wheezing, a cardiovascular murmur, specifically tricuspid regurgitation, which we know is a holosystolic murmur, and diarrhea. The best initial diagnostic test is a urinary 5-hydroxyindoleacetic acid test. This is the breakdown product of serotonin. The treatment is octreotide. Octreotide is a synthetic version of somatostatin, and somatostatin basically shuts off all bowel hormones. Therefore, it helps in the symptoms. Lactose intolerance is when we have a deficiency of lactase. Therefore, we cannot digest lactose. These patients have intermittent symptoms because you don't always eat lactose. There is no weight loss because it doesn't affect other caloric intake, and you have normal vitamin levels because the bowel wall is not affected. The best initial diagnostic test is the stool osmolality test. The most accurate test? It's simple. Stop eating the food and see if your symptoms go away. The best treatment? You guessed it. Stop eating milk products and consider exogenous lactase therapy. Irritable bowel syndrome is a pain syndrome with either diarrhea, constipation, or both. The pain of IBS is relieved by bowel movements. It's less at night, and it's relieved by a change in bowel habits. There's no specific diagnostic test. It's a diagnosis of exclusion in association with a complexity of symptoms. What you should know is that it's not associated with weight loss. You will never see blood or white cells in the stool. The treatment of irritable bowel syndrome is quite varied. First, you can consider increasing the fiber in their diet. You can consider an antispasmodic agent such as hyoscyamine or dicyclomine. Tricyclic antidepressants such as amitriptyline have helped because there is a mind-gut connection associated with irritable bowel syndrome. Antimotility agents also work. Loperamide for diarrhea-predominant irritable bowel syndrome is helpful, and lubiprostone, which is a chloride channel activator, is good for patients with constipation-predominant IBS because it increases the bowel movement frequency. Inflammatory bowel disease is an autoimmune condition with multifactorial causes and two specific types. Crohn's disease and ulcerative colitis both present with diarrhea and abdominal pain, blood in the stool leading to anemia, weight loss, and fevers. Both diseases have extraintestinal manifestations that are tested often. Arthralgias, uveitis, iritis, skin manifestations such as erythema nodosum or pyoderma gangrenosum. The last one, sclerosing cholangitis, which is a USMLE favorite, is more frequent in ulcerative colitis, but is common in both. The risk of cancer is also associated with both Crohn's and ulcerative colitis. Both forms of IBD can lead to colon cancer. The cancer risk is increased with duration and severity of mucosal injury. So the longer you've had the disease and the worse you've had the disease, your cancer risk goes up. Crohn's disease that involves the colon has the exact same cancer risk as ulcerative colitis. The image on the left is a patient with erythema nodosum. The image on the right is a patient with chronic pyoderma gangrenosum. We've talked about the similarities of both diseases. Now let's talk about the differences. This is where you score your points. Crohn's disease will have skip lesions. Ulcerative colitis can be cured completely by surgery. Crohn's disease has transmural granulomas, the entire bowel wall. Ulcerative colitis is entirely mucosal. Crohn's disease has fistulas and granulomas. Ulcerative colitis has no fistulas and no abscesses. Crohn's disease can present with masses leading to obstruction. Ulcerative colitis has no obstructions. Crohn's disease has perianal disease. Ulcerative colitis is anal sparing. Now here's a tip. A frequent question that's asked everywhere and by everyone is, when should screening for colon cancer begin? The answer is after 8 to 10 years of colonic involvement, with a colonoscopy every 1 to 2 years thereafter. The mainstay of diagnostic testing for inflammatory bowel disease is 100% endoscopy. It is the most accurate test. Keep in mind, endoscopy can reveal all sorts of problems with the mucosa. Ulcerative colitis on the left, Crohn's disease with the skip lesions and cobblestoning on the right. It can also get you biopsies so you can see the chronic inflammation. Radiologic testing can pick up some lesions, but the sensitivity is low. It's only used to detect strictures in Crohn's disease. Antibody testing is possible, but it's only true in 2/3 of the patient and is only used if the histology is equivocable. There are 2 serologic tests, ANCA and ASCA. Each one is specific to a different disease. ANCA, or anti-neutrophil cytoplasmic antibody, is negative in Crohn's disease but positive in ulcerative colitis in 2/3 of patients. Anti-Saccharomyces cerevisiae antibody, or ASCA, is positive in Crohn's disease and negative in ulcerative colitis. Acute exacerbations of either Crohn's or ulcerative colitis are treated with steroids. They are then maintained chronically into remission with 5-ASA derivatives of mesalamine, specifically Asacol for ulcerative colitis and Pentasa for Crohn's disease. Perianal Crohn's disease is treated with ciprofloxacin and metronidazole. Azathioprine and 6-mercaptopurine are used to wean patients off steroids and maintain them in remission. Patients who have fistula and severe unresponsive disease need to be on anti-tumor necrosis factor agents such as infliximab. Remember, these patients must have TB testing done prior to the administration of infliximab. Surgery is only done if there's then no response to the anti-TNF agent. Remember, neither form of IBD is routinely treated with surgery. Ulcerative colitis can be cured, however, with a colectomy, and in Crohn's disease, surgery is used exclusively for bowel obstruction as it can recur at the surgical site. Diverticulosis is an outpocketing of the colon that's very common in 65 to 70-year-old people. It's where the artery meets the mucosa. Those are weak points. The colon then begins to outpocket in those little areas. Vegetarians rarely develop diverticulosis. Patients who are at risk are those who eat a meat and potato diet. Remember, it's really an asymptomatic disease until you have a bleed, or you develop infection, such as diverticulitis, which presents with abdominal pain, sometimes even bleeding, and if it's very complicated, abscess formation. The most accurate test is a colonoscopy. Barium studies are acceptable, but they're just not as accurate. What's the treatment? Fiber, fiber, and fiber. Increasing the patient's bran intake, psyllium, methylcellulose. Any dietary fiber can decrease the rate of progression and complications. Diverticulitis is when one of these outpocketings becomes occluded and then subsequently becomes infected. Patients will present with left lower quadrant pain and tenderness. However, it can be anywhere in the colon. The left lower quadrant is the most common. They will have fever, leukocytosis, and at times they can even have a palpable mass. Symptoms such as nausea, constipation, and bleeding can be present but are extremely nonspecific. The best initial test is a CT scan of the abdomen. It actually has a 98% accuracy. A colonoscopy and barium enema are dangerous in acute diverticulitis. There's an increased risk of perforation because the infection weakens the colonic wall. So think about it. You introduce a colonoscopy. You inflate air with the colonoscopy. And then your weakened bowel wall goes pop. Here's an example of diverticulitis in the left lower quadrant as detected by a CT scan. We treat diverticulitis with antibiotics that cover E. coli and anaerobes. These can be ciprofloxacin combined with metronidazole, amoxicillin and clovelinate, ticarcillin and clovelinate, or piperacillin and tazobactam. Who gets surgery? Surgery is for those patients who do not respond to medical therapy, who have frequent recurrences of infection, or patients who have one of the following: perforation, fistula formation, abscesses, strictures, or obstruction. Which of the following is the most effective method of screening for colon cancer? Is it A, colonoscopy, B, sigmoidoscopy, C, fecal occult blood testing, D, barium enema, E, virtual colonoscopy with CT scanning, or F, capsule endoscopy? The correct answer is A, colonoscopy. It's been recently shown that colonoscopy reduces mortality. The reason we like it is because it also allows for biopsy. Since 40% of colon cancer occurs proximal to the rectum and sigmoid colon, sigmoidoscopy is not nearly as sensitive. Fecal occult blood testing and barium enemas are also less sensitive and do not allow for biopsy. Virtual colonoscopy with CT scanning has low sensitivity, misses small polyps, and if it does find a polyp, you still have to get a colonoscopy. Lastly, it doesn't allow for biopsy. F, capsule endoscopy for small bowel bleeding only. Remember, the only indication it has thus far is for bleeding that has been ruled out from an upper and lower source. In the United States, patients should have a colonoscopy every 10 years beginning at age 50. But what if they've had a single family member with colon cancer? Then they begin 10 years earlier than the age at which the family member developed their cancer, or 40, whichever happens to be younger. We screen every 10 years if the relative was greater than 60, or every 5 years if that relative was less than 60. Now, let's clear up some issues about hereditary non-polyposis colon cancer syndrome. It must comprise 3 family members, 2 generations, and 1 patient with premature colon cancer. For these patients, we start screening at age 25 with a colonoscopy every 1 to 2 years. Familial adenomatous polyposis is the presence of thousands of polyps in a carpet-like fashion with abnormal genetic testing known as the adenomatous polyposis coli test. We screen these patients with sigmoidoscopy at age 12 every year of their lives. What if you're presented with a patient who had an adenomatous polyp on a previous colonoscopy? You should then tell them they should have a colonoscopy every 3 to 5 years thereafter. If they have a previous history of colon cancer, then this patient should have a colonoscopy 1 year after resection, then at the 3-year mark, then every 5 years. Peutz-Jeghers syndrome is when patients present with multiple hamartomatous polyps, melanotic spots on the lips and skin, increased frequency of breast cancer, and increased gonadal and pancreatic cancer frequency. Gardner syndrome is when colon cancer is associated with osteomas, desmoid tumors, and other soft tissue tumors. Turcot syndrome is colon cancer in association with CNS malignancy. And lastly, juvenile polyposis is colon cancer in association with multiple hamartomatous polyps.